Next session would be on clinical stewardship. Speakers are Dr. Arvind Kumar, Additional Professor, and Dr. Manish Soneja, Additional Professor, Department of Medicine. They are accompanied by Dr. Mohit Chaudhary, Junior Resident pursuing DM Infectious Diseases. All of them are from AIIMS, Delhi. It is a great privilege on our side to have them as our eminent speakers. Dr. Arvind Kumar, who has come all the way to AIIMS Patna, is not only an academic achiever, but has a very practical approach towards patient care. He has been awarded with many prestigious awards and appreciation letters for his contribution towards different aspects of healthcare. I would like to call upon our speaker to enlighten us on clinical stewardship. He is also accompanied by Dr. Mohit Chaudhary. Dr. Manish Soneja has joined us online to enlighten us from his knowledge and experience. Please, sir.
Good morning and a warm welcome, ladies and gentlemen, respected faculty members across the country, and my dear residents, who are and would be the backbone of this stewardship program for which we all are gathered here. And it is my privilege and honor to be a part of this learning session, growing together with faculties and residents from various departments. And I express my gratitude to the organizer, head microbiology, and the organizing secretary, as well as those brains behind this very stewardship program, kind of coalescing different departments under one umbrella. Dr. Panda, a journey of 4 years since when it was started. It is a great kind of, I must say, a process which has been started and the need of which was felt since long. So, as disclosure of my presentation, I must say that whatever I am going to speak here is all the work of Department of Medicine, All India Institute of Medical Science, New Delhi, under the dynamic leadership of our head, Professor Naveed Vig, and assisted by a very dynamic faculty member, Dr. Manish Soneja, because I have seen the change. I have seen the change of inclusiveness of everyone in the department, because I was there when our head became the leader, and the way he included everyone, and the change was felt, the process was felt. So everyone now has ownership and they are part of team of this stewardship. So ladies and gentlemen, I begin my talk with this very great quote or idea of Garrett Hardin, a famous ecologist from US, where you can see this field, the limited field, where sheep are having their food, and the number as it increases, but because of the limit, you have seen a change of color. So what he meant by this slide is, unless environmental costs are accounted for, an address in land, and land for us is now, it is antibiotic, the practice, eventually this land or this antibiotic will be unable to support the activity that we are doing. So when these prescriptions of antibiotic, अब बैक जाइए, prescription of antibiotic, first slide please, happens rarely, the harm to the society isn't noticeable. But when it happens in tens of millions of times per year, the collective harms to the society is catastrophic. Next. So, by saying this, I mean, why we are worried then? What's that to our antibiotic? Next slide. So by first, second slide. Why can't you make this slide rolling by this? हाँ वो ठीक है, इसके पहले जाइए. Well, I have tried to show to the residents here that as we are progressing year by year, the bacteria, the microbes which are resistant to groups of antibiotics, they are increasing their number. So, if they are increasing the number, what is the problem? The problem is, as shown in this slide, that by 2050, we are going to surpass cancers, all metabolic diseases as a cause of death from antimicrobial resistance. So, and at the same time, if you see the cumulative loss of GDP, it is going to be about $100 trillion if you see the cumulative effect over these years. So, and if you see this, the death slide, and focus on our scenario, this is much more for our Asia continent. So that means we are the ones who are going to, be the real sufferers. So what is the problem? I mean, what are the contributing factors driving these antimicrobial resistance? So, well, there are many factors tabulated here, but I just want to focus towards the use and misuse of antibiotics not only in humans but also in animal. And they are the major chunk of these contributing factors which are causing this antibiotic resistance. So by saying this, my point of concern to make you aware and understand was One Health. It's not that we are gathered here to do stewardship, that we only take care of our health, human health, and then we'll succeed. No. It's animal health, it's plant health, the health is one. If you're not concerned with this whole health in a holistic fashion, you are not going to succeed. So this concept of One Health, as shown in these WHO slides, if you see this cycle, precisely, which has been worsened over years by mass medications with broad spectrum antibiotics without any regulations in these animals, which in turn enters into our food cycle directly, indirectly, and makes the scenario worse. So the point is that we have to think in a larger extent, in the larger surface. It's not that only we are concerned. The concern has to be in a fashion that we are making an umbrella of One Health and incorporating everyone. Next slide. So this is a slide taken from just a medical practice which is not related to stewardship, but yes, the implications are that in a patient care, in whatever field you are, whatever we are practicing, and wherever our medical knowledge is, there is a gap. There is a huge clinical implementation gap. The factors, the reasons behind it is multifactorial. multidimensional. But yes, this stands true for antibiotic stewardship program, the clinical stewardship program. We'll come to it one by one. So, if there is a gap, so what is the problem statement? In this AMSP guideline by ICMR, 30% of all hospitalized patients at any given point receive antibiotics, and around 30% are inappropriate. See, the percentage is huge. 30% of the prophylaxis given in surgical wards are inappropriate. And the cost, the lost is also around 30%. So, the point is that we have a big challenge. We have a big burden. So, if I wish to sum up these challenges, this could be subdivided into leadership, commitment, systems and regulations, failing to the demands, AMS interventions, and lack of adequate infrastructure. So in principle, nation and state, our lack of action plans for this particular problem that we are facing. And at this point of time, either we are not able to approach to that leadership where we should be, or either we ourselves should stand up in that leadership to make adequate provision for this slacked political commitment. So, if we talk of systems and regulations, at this point of time we don't have a very strong and good regulation. Irrational fixed dose of combinations, you can see, whatever you follow, every year some drugs are withdrawn, some new combinations come up, and many of them would be withdrawn in some point of time. So it's happening on a regular basis because we are lacking in regulations, the good regulations. The quality of medicine at some corners are questionable. The over-the-counter availability of drug and the intersectoral commitment, the coordinations between environment, the veterinary issues, the aquaculture is lacking. So if it is there, it's a very nascent stage. Next slide. This is beginning that we are into for last 3 to 4 years. For many years after Chennai Declaration, many things were very silent, but yes, we have come up. So, once we talk of infrastructure, most of us are coming from central universities, central hospitals, but the situations in the peripheral government medical colleges, the peripheral hospitals, the private hospitals are worse. Worst. It's not kind of, blame and game here, but the thing is this key, we have to find a mechanism to incorporate each one of them in a gradual and a persistent manner. So, if we are, with all these problems, we have to have this willingness of AMS interventions. Because at this point of time it is patchy and the functional models are very less. So, even if you have known these all challenges, what are the biggest barriers? The biggest barrier is our behavior, our egos, to go and talk to different departments, to make a group, to make a system, to make a coordination with microbiologists, physicians, clinical pharmacologists. इधर दिखाना होगा, नहीं चल रहा, नहीं नीचे करना है, तो पीछे करना है, यहाँ वाला पीछे. So these barriers are behaviors which we have to be curtailed down. Next slide please, it is not working. Next slide. So what are the AMSP core elements? This slide is directly taken from WHO. I'll go one by one. So the first is hospital leadership commitment. So we have to have dedicated human resources, financial resources, and IT persons in place. A leader and a co-leader who have accountability, such as physicians, pharmacists, microbiologists, nursing officers, and other healthcare officers which are working in coordination with ASP program. Pharmacy expertise, which were called as drug expertise previously, plays a major role. We have to have a clear-cut action plan with implementation of interventions, have to have a tracking system that we are doing, and we need to follow them in a very close manner. A reporting system with a regular report information on antibiotic use, the pattern of resistance, and educations. Educations to almost all human resources from every sector, which are going to make this antibiotic stewardship program a success. Next slide. So I'll come to ground zero, and we like to take our shortcomings one by one, giving them different headings, directly example from our whatever we have learned from our mistakes from our department. I have tried to make 5 subgroups. The antibiotic part is basically the one who are prescribers, an antibiotic itself. Then the microbiologist, pharmacist, the samplers, the sampling process, and HIC practices. So I like to tell you that these are a standard theory where these shortcomings are dealt, but I would like to tell that where we have lacked and from where we have learned to build upon that. Next slide. So when we looked back to ourselves, we found that the prescriptions for many of them were unnecessary. There were redundancy rates were high. There were dosing errors, there were poor choices. Many of us were ignorant at the time of prescribing some antibiotics. We needed some specific instructions. We are unaware of the PKPD of that drug. It's very simple but important. The switching from IV to oral was inadequate. The lab reports were not given attention at the right time, in the right manner. Microbiologists worked so hard, beyond doubt, but those experiences, those observations were not tabulated at the right time to project as Antibiogram in a frequent manner. Just a lack of kind of inputs, thought. Must accept that the licensing was also poor, which we are now working upon and growing gradually with microbiologists. The culture reports were delayed many a times. The factors may be various, and we have to work upon, why not a kind of a system where we can send sample round the clock 24 hours. We are building upon that, we will build. But things are very lacking at peripheral centers where we need to work upon. Formulary restrictions, if you talk of the pharmacy part, is basically a theory. If you see, in our experience at AIIMS, New Delhi, the patients referred from a private hospital, even if you talk it in principle that you are not to use these kind of broad reserved antibiotics, the patient has already taken it. So it's not very well into place, these restrictions, which needs to be at this state. The choices between departments are varying in single institute. Even if you have Antibiogram, people are playing with their experiences on the name of experiences. I am giving this, I am giving this is what my observation is. So once we have your experiences changed into data, there is no place of this. At least in an institute where you have developed your own Antibiogram. The empirical therapy is excessive. If you move to periphery, the residents would be also knowing very well the antibiotic uses in the empirical manner. They are literally playing with us, playing with antibiotic. As far as the infection control program is concerned, we need to have to strengthen it more and more. Next slide. So knowing this, next slide please. Knowing this, our problems, we try to gather and build upon one by one, which I like to put it as published evidence from Department of Medicine. So this was published in 2017 in National Medical Journal of India, where we did a quasi-experimental studies among residents and physicians in a 3-phase manner, interspersed one phase with training and education with various means, including lectures, feedbacks, WhatsApp group, Facebook group, posters. And what we found that the results were very encouraging. The de-escalation, right escalation, the overall use of appropriate antibiotics, the cost benefit was tremendous by this simple study done over 2 years, and we found that many of them were significant to our utmost satisfaction. So this is what was rewarding after reading our problems, our shortcomings, and building upon that with training programs and putting them into literature. Next slide. Further, this was a study in one of the units of the Department of Medicine where we took initiative and put a day 3 bundle. I'll come afterwards what is day 3 bundle is, but we put it in the same kind of study of quasi-experimental study where 2 phases of observation, pre and post, was interspersed with intervention in terms of education, and we found that we were able to significantly reduce the unnecessary antibiotic use, the duration of hospital stay, as well as the close follow-up next of adherence to day 3 bundle after an intervention. Next slide. So this culture of training among ourselves, we grow further, and this was again a study back for all the MD medicine residents, DMID residents, that we try to study the trainee-driven antibiotic stewardship program in a high burden resource limited setting. So what we found that the cultures of culture we were talking about in the previous talk, we built better on that after study. The positivity rate started coming at right time, the number also increased, and if you see the redundant coverage of anaerobic with already given a spectrum of antibiotic which is already covering anaerobic gone down significantly. The unnecessary combinations of many antibiotic also went down. And you can see the uses of carbapenem which were very heavy over 1 year during this study went down significantly. This was also rewarding. Next slide. In diagnostics, this is not published, but this is an unpublished data, with the support of Department of Microbiology, with mildly-tough, we found that we were able to reduce the time of culture, the time of the report, awareness of which microbe is there was reduced from almost half, and we were able to make a choice of empiric antibiotic on the very next day, because we had already got the hint of which microbe is there through mildly-tough. Next slide. So as you can see here, the mean reporting time with sensitivity was significantly reduced post interventions with these mildly-tough, Pactec, compared to the conventional use of culture methods, and they were significant. This study done by Vishak and Dr. Manish et al. So we also built upon that. So we need to incorporate more and more, wherever we are, different teams involved in this stewardship to build upon. Next slide. So knowing all this, let's come to the rational use of antibiotic. So for residents, I would like to give an example of every step of this through a case. That what is this rational use? So there are fixed components to it, whether it is needed, whether there is infection or not. Have we reviewed the de-escalation, escalation at the right time? What was the duration? What dose and which antibiotic? So I'll give two clinical scenarios of urinary tract infection, because that would be next. So what are the core competence of as far as the UTI is concerned? So as the part of this team or clinician, we have to understand the patient need and clinical need. We have to understand the treatment options, work in partnership with patients and other healthcare professionals, communicate the treatment plan well to rationalize it in a better way, and monitor the patient's response treatment. So why this is important is that because as far as you know, this UTIs, many a times you can, I'm just giving simple examples, that if your preliminary steps is not good, you can catch up unnecessary things to read, to land upon the misuse of antibiotics like asymptomatic bacteria. One should know where it should be sent, where it needs treatment. The complexity of analysis, and many times we are misguided by unnecessary contaminations, and the knowledge of local evidence-based antibiogram. Next slide. So we should understand that we can have scenarios where, besides UTI, where you have a true culture positive, you can have scenarios like this of asymptomatic bacteria, contaminated cultures where you would have the plates showing culture positivity. Next slide. So as you misuse these antibiotics, you are going to have more and more resistance, nothing special in this slide. Next. So let's take part 1 of asymptomatic bacteria. So I'll go this by example. Next slide. So first, a clinical assessment of a case. Next. So a 44-year-old young lady with a positive urine culture 3 weeks ago, with urine culture performed because of dysuria and infrequencies, treated well at that time, now doing very well, no symptoms, normal examination, but she has a concern, so she has come to us. So my questions to you, dear residents, so should we submit another sample because she has come to you? Yes or no? So you can raise your hand even if you don't want to speak, or you can make your answers ready. Any one of you? You can just raise your hand. Should she submit another sample because you have to prescribe? The patient is worried. So you just have your answer in your mind. I'll go to next slide. So what could be scenarios and when you should rightly send a urine sample? It should be sent when you suspect UTI. So whether you are suspecting UTI or not in this patient, that is the question. You have to have an objective answer of this, because it's not that you are treating just the report and you need to just find this unnecessarily reports of contamination, bacteria which doesn't need a treatment, and then you go for unnecessary treatment which we come across many a times. There could be problems in the interpretation with lot of epithelial cells, and we know very well that where these asymptomatic bacteria should be treated. So again, what I am making out of it is this tradition of curing culture should not be performed, and for that purpose culture should not be sent. So there are a few residents who raise their hands. Next. So the answer to the question is no, because she was asymptomatic, there is no indication for the culture, patient just needed education. But the question is, how many of us, how many of the physicians in the periphery does this? The answer is very sad. You can find 20 or 20 reports of E. coli of different numbers with nothing, and patient is getting antibiotic for months and years. This is something that we need to realize now and take it to every prescriber that what wrong he is doing in a conducive manner. The second part which I'll try to give as an example is how do we use guidelines to manage these kind of cystitis. Next. So again I'll come to clinical assessment with another case scenario. Dear attention, residents, your attention please. So 45-year-old young female with complaints of dysuria, frequency, denial of any vaginal discharge, with subjective fever, with normal physical examination, and she has already received 2 months of co-Trimerox from periphery, and now she also has come to you and she is symptomatic. So the difference from the previous case is she is symptomatic. So now these 5 components should be there based on your you should answer with your baseline competency to use optimal antibiotic. Am I going very slow, Dr. Panda, or should I hope I am not consuming much time. So optimal antibiotic should be used. So the patient is stable. The source we have known that is cystitis, and the most common pathogen we know by our background knowledge is E. coli. As far as the resistance is concerned, we know that there is a recent use of antibiotic. Yes, you know the name of the antibiotic also? Back. So knowing this, we should have the data. And if I talk of my setup, I have a data of that month of when the patient came. Next. Which shows that most of these OPD and IPD patients with these kind of uncomplicated cystitis are sensitive to the nitrofurantoin. But still, next. Knowing this, we have to have then certain guidelines based on our Antibiogram. If we don't have our own guidelines, we have to use one standard national or international guidelines. So as we see here, the common antibiotics which are effective in this, given by IDSA. So we need to pick one of them, seeing the patient's use of antibiotic in past days, the patient's own profile of allergies, and the therapeutic decision has to be made, and we have to pick one antibiotic among whichever now is available. So at the time of prescribing this empirical antibiotic, the culture needs to be sent, which was wrongly sent in the last case, and we all know that what is the right way to send this urine culture, which has to be percolated to each and every patient through us. So now you have made a choice of nitrofurantoin in this patient. What next? So what about duration? Is it we decide duration? It's, let's say, 3 weeks now, nitrofurantoin. Pick the duration from the guidelines. It's 5 days for nitrofurantoin in these kind of conditions, and 3 days and 1 dose for cotime mox and fosfomycin respectively. So we have make your decision as well as patient education. So what after this? So after this initial kind of decision, we have to now follow the patients on almost daily basis as far as this antibiotic usage is concerned. And then we have built upon duration. So after dose and duration comes the mode of antibiotic uses. This is a simple case, but in many scenarios there could be next. So we need subsequent evaluation, which needs to be on daily basis. Next please. So in the subsequent evaluation, we should know, are we right in what? Right in antibiotic, patient, time, dose, route. So we have seen this, we are right in antibiotic, patient, time, dose, duration, but what about route? Which will come to this, because these right steps will ultimately help us into clinical stewardship. And this is just an example. You can extrapolate it to any scenario of any organ systems infections or in sepsis. Next. So we saw here the ITSA guideline, the national guidelines, but we over times at AIMS, we have developed our Antibiogram, which is in form of a mobile app, and it is readily available to all the departments made by Department of Medicine. This Antibiogram in a apps based system, which tells us about what antibiotic is to be chosen. Next. So once we come off duration, there are ample of studies which tells us that these many antibiotics, starting from carbapenems, lactams, and other antibiotics, about different duration of treatment, and whatever outcomes they have taken, that short duration, this is for CAP, for cellulitis, for VAP, these short durations were equally effective as long durations. So unnecessary use of prolonged antibiotics is to be avoided, and same with this UTI. Next. We should also know that what are the antibiotics with good bioavailability if taken orally, and they should be used promptly whenever patient is fit to take orally, if at all they have started on IV at right time. Next. So this slide is important because now we are talking about route and frequency. So, knowing this, there are group of antibiotics. Next slide, please. Because we have to have knowledge of PKPD, I've just tried to tabulate the 3 groups of antibiotic, which has concentration-based killing and time-dependent killing. And the third is time-dependent killing with a moderate to prolonged persistent effect. What I mean by saying this is, the residents, that if you know this, you will choose which antibiotic is to be given in infusion over many hours and which are to be given in bolus form, because in bolus form you are only concerned with the peaks, and with the antibiotics where you need that they are effective and they are in time dependent killing mode, they are given to be in infusion form. Next slide. So this has been there. And in this forest plot you can see these carbapenems, beta-lactams, almost all the studies have suggested that these antibiotics given in infusion form over prolonged hours are much more effective and favors the prolonged use of antibiotics. Next slide. So earlier in the presentation we talked of ideal team. So ideal team comprises of, which works in a particular unit, a center, a department, a physician, pharmacist, pharmacologist, nurse, operator, microbiologist. The ideal committee is basically works for an institute or for many departments which looks after these different teams. So we have deliberately removed the first ID physicians. We believe in this, that whichever person is taking onus from whichever department, that clinician should be a part of this committee and not only ID physicians. So there is nothing like ID physicians to me or to us. If everyone, whosoever is using antibiotic in any department are ID physicians. So the clinicians is must. And then stakeholders from different departments. So knowing this team and getting wisdom from what is being done from outside, we wrote editorial to JAPI, and thanks to them, they admitted this and published it in this letter to editor, fashion, where we felt that those dimensions, those human resources which are left, the nursing staffs, the baseline healthcare workers, whoever is willing to contribute in this stewardship, must be included in this stewardship program, which we felt that was missing. Next slide. So knowing this, we have to have a balance as far as this stewardship program is concerned between patient therapy to maximize the benefit and selection of resistant pathogens, and to minimize the selection of resistant pathogens by optimizing our therapy. Next slide. So this balancing needs a good intervention. So what is that intervention? Few of the headings we have already seen by the head microbiology aims here is prospective audit and feedback, that is the real essence of stewardship. The pre-authorization, the formulary restrictions, didactic educations, though the evidence of the benefit of didactic education is less, but yes, that can be done on a regular fashion to minimize the inappropriate use. The development and implementation of facility-specific clinical practices, policies, guidelines of all the steps, including antibiotic guidelines in ASP, and close liaising with everyone, the microbiologist, all other participants, to make it a grand success. Next slide. So what we did and what we are doing. This audit, because we are more kind of not that, because if I am doing something, the baseline learning is this, I am doing, I am probably it's right, why someone is intervening me. So we try to make a system with our ID team, where an ID resident, a senior resident, after every emergency goes and checks the file whether the decision is taken by a faculty or a resident or a emergency registrar, and he makes his own note depending upon those guidelines of antibiotic uses, the dose, the choice of the antibiotic. And that evening, in those medical wards, he gives the feedback to his colleague residents of that unit that this is probably not good. So this feedback system is working very well, and now this feedback given to SR comes to the faculty on the round, and it is discussed in a very cohesive manner, and the changes that are required are made. So we have tried to devise a mechanism that these changes, these persuasive changes, are very conducive and kind of, learning for all of us. So audit has now shown that this has helped us, and as shown in many of the studies which have been published, that the selection has been appropriate, the escalations, the de-escalations, the dosage adjustment has been very good, the routes, the shifting to oral antibiotics, the redundant use of antibiotics to cover unnecessary has gone down and down, and overall it has used our practice. Next slide. So how we are doing with these formulary restrictions? We have categorized certain antibiotics like colistin, teicoplanin, higher lactamases, that those would be only and only implemented in consultation with the faculty on call. So this is the way we are going. Many other ways can be devised, but this is how we are playing at our institute, and that has also played very well. Supporting this, the Cochrane analysis has shown that these restriction and pre-authorization have been shown to be more effective and persuasive strategies that we just saw, the feedback mechanism. But whether it is true for our scenarios, I don't know. But yes, what I feel personally, that, next slide, this pre-authorization and feedback system, kind of a boss culture, not boss culture, a right boss culture, a kind of a, and then kind of a feedback mechanism has to be interspersed very well. Until unless we mix both of them, as far as our stewardship, we will succeed very well. So because there are some benefits of one, there are some benefits of other, we have to take both of them and then work together. What is pre-authorization? It reduces the initiation of unnecessary antibiotics, direct control of antibiotic by certain, decision makers. And prospective is a real kind of learning for the whole group, starting from resident, senior resident, everyone. So but it has its own limitation. If you open all the antibiotics for this audit and feedback, on the very first day it would be written by the registrar in emergency. So that is how we are trying to control mixing both these initial steps. Next slide. So we also propose, and we are doing this, as early as you find fit, you switch to the antibiotics which has good oral viability. Next slide. So earlier I talked to day 3 bundle approach. What is that? A proper plan, review of diagnostic labs, positive microbiology report should be reviewed as soon as possible, and proper changes in de-escalation should be done as soon as possible, and switching. So the result of the study I have already shown that we did, and we found it beneficial. Next slide. So I have just tried to brought 2 forms which we are doing. The first is basically of feedback system, where the ID registrar is filling it after patient has been transferred from emergency, or even if it is in emergency and is already admitted in medicine. The system where the patient has infection, the antibiotic uses, whatever cultures are already available, on which antibiotics were given outside, what are the changes made, what are the patient's profile of antibiotic usage in the past. And the this is day 3 bundle, for which what kind of planning is done for day 3 bundle, whether the treatment was already planned on day 1, the consideration of lab diagnostics is already considered for the further plan. The culture has been taken into account on 3rd day, and antibiotic has been changed in a certain way. So these are things which are going. There are many forms which we see. I mean, we'll see in the other presentation. But these are 2 of them which we are doing. Next. Didactic education has been shown that they are not very sustained, because the way we are doing, I mean, we cannot just make changes by telling by these lectures. It has to come in our practice, and making to come into the practice, we have to have the kind of persuasive interaction, the other steps. Next slide. So it is against, but yes, it is an adjunct with other steps. Next slide. So one of the preface I have shown that how we have developed Antibiogram over the years in Department of Medicine, and we have been collaborating with different departments, whosoever is using antibiotic, together with taking into company of pharmacist, microbiologist, the ICU intensivist, and how they are made, because on the daily basis we are developing our antibiogram. Whichever cultures are grown, the antibiotic patterns are feeded, and they are presented in the department's meeting on a weekly and monthly basis. So we have ready to use antibiogram to each stakeholders, whosoever is a part of this ASP. So this mobile application is free to use, and to our satisfaction, it is being used all over the country now. About 70,000 downloads are there of this app uses, and more than that, it has given the stimulus to colleague institutes, the departments, to make such kind of their own antibiogram and policies. Next. So as you can see, this is on slightly older dates. We have 70,000 downloads. So if you open this, you have the basics, you have syndrome, system-wise approach, and table tools for different syndromes. So one can easily and handily use bedside without any problem. Next slide. Next slide, please. So what if one doesn't have these local antibiograms? Yes. So whatever we have at a national level, the ICMR guidelines, the NCDC guidelines for antimicrobial uses, that should be implemented, that should be encouraged. And experience should not be followed blindly. Yes, if there are eminences of experiences, tabulate them, make your data, show it, and then use it. Because phrasing experiences deceives us. Next slide. So these datas in monthly meeting are presented by registrar ID. So infection profile, cultural practices, antibiogram of every month is presented, the rationality is presented. These changes have been tremendous under the leadership of our head, Professor Naveed Vig, and has been learning for every one of us, all the faculties, resident staffs. So this is going on. Next slide, please. So the POCT lab, which we have made in our ward itself, with certain microscopy and staining methods done by ID resident itself to minimize, to have the preliminary report, certain point of care diagnostic tests for malaria, strep typhus, dengue, other point of care tests related to infections, the procalcitonin, and to rule out pro-BNP and troponin are done in that POCT lab itself. That has been a major change in the recent time. Next slide. So my dear friends, are we doing it right? Or are we saving that one patient by giving all broad spectrum antibiotics and planning to kill many others in future? This is a time to think and rethink, introspect for all of us. With this, I would like to come to take home message. Next slide. That AMR burden challenges are immense and may be devastating in future. The answer lies in each one of us. Our teamwork, that is the key. Go to that slide again. Killing personal egos, units egos are must. We must learn from our experiences, observation. But these experiences should not be just an experiences. They have to be translated into data for everyone. It cannot be one's experiences. Units, department, institute must change these data into and to make available to all stakeholders. And based on that, your policies, guidelines related to antibiotics, diagnostics, clinical practice related to AMS has to be modified. The implementation has to be cordial, with no offense, in a loving manner, mutually respectful manner, mixing with formulary restrictions and pre-authorization, that because that is scientific, from all resources in a way, and to carry it forward. Thank you very much for your long patience hearing. So the sessions given to us, still is on. So if one of us, our senior faculty member, Dr. Manish Soneja, is online, and I request him to now come on online and then give his expert comments to carry this session forward. Dr. Manish, sir, please.
Thank you so much.
Please increase the volume again.
Yeah, thank you so much, Arvind. And hello to all my friends. Happy to see our team back again together after this forced break caused by COVID-19. And all of us, COVID had hit us badly in various aspects. And in particular, the antimicrobial stewardship practices has been badly hit. Nowadays, data globally, we have analyzed our data. The AMS practices has been badly hit during this period. In fact, many years of progress has been undone. Whatever we had achieved over many last 6, 7, 8 years, step by step, gradually, we saw COVID pushing us back, and many of the gains have been undone. That is also visible in a changing antibiogram profile. So now all our focus is on how to regain this, how to gain back whatever we have lost and improve upon it. The major challenge is that many of the things are related to behavioral aspects, in particular infection prevention practices like hand hygiene, etc. And all of us know it is very easy to catch a bad habit, but very difficult to build a good habit. So now we again have to go back and start afresh, improve the things, and it is important that we innovate and share ideas how we are doing this. So this is a platform which provides us the opportunity to discuss and deliberate. So at our place, we have again restarted after the break, introduced the old tools that we were using. We have added a few new tools from the last time we have met. We have added a few new tools now that we will discuss. But it's very important that we discuss all these things, share ideas.
Hello everyone. I'm Dr. Mohit Chaudhary, undergoing junior residency in the course of DM Infectious Diseases under the Department of Medicine and Microbiology at AIIMS New Delhi. First of all, I would like to thank Manish sir for guiding us through all the practical approaches that we have done in our ward related to antimicrobial stewardship. I would also like to thank Arvind sir for giving an in-depth view of the burdens and challenges of the problem, the ground realities, the mistakes that we are doing, and the interventions that we can do to improve it. So, continuing with the presentation. So here is a list of activities that we do at ground zero, that is at our ward, at our department here at AIIMS New Delhi. So starting it with the creation of an antibiogram. We'll discuss this in the next coming subsequent slides. The works and duties of the ID1 team, point of care lab which we have in our ward. Something about formulary restriction, points about the point prevalence study that is conducted monthly to enhance the culture of cultures as well. The prescription audit that we have here, and the AIIMS antibiotic policy. Now, a few things have already been discussed by Arvind sir. We'll just make it brief and short to list out the practical points related to it. So, about the antibiogram, this is updated annually and monthly as well, and we have a presentation for the same regarding the changing antibiogram and what should be our approach to it. Now, the target for the Amsp practices is to cover 10% of the total beds of the hospital as of now, comprising of 10% of ICU and 10% of non-ICU beds. Now, this data is generated actually with the collaboration of HIC laboratory, which consumes all the culture positive results that are coming up in a particular ward in a particular duration under a particular department. Now, one thing is kept in mind, that this is made specimen wise. And to make it specimen wise and to make it significant, that is to take the sensitivity as significant, there should be a minimum of 30 isolates in each 30 isolates of each organism in that particular specimen, in that particular ward, if we mean, in a particular duration. Now, the drawbacks with this, there are certain drawbacks. Like since this is a collected lab data, we can't actually screen it to exclude the non-significant isolates, which are clinically non-significant. And there are certain repeat isolates from the very same patient having same sensitivity. So again, that cannot be excluded in this. Now, here is a demo of the antibiogram that we prepare. This is the anti 2021.
Thank you, Dr. Arvind Kumar, Dr. Manish Soneja, and Dr. Mohit Chaudhary for the wonderful session and for pointing out the ground level situations. Listening to you is like an educational feast. Our audience would certainly take up your messages and carry them forward. Now, I would like to call upon on stage Dr. Bhaskar Takuria sir to present a memento of appreciation to our honored speaker, Dr. Arvind Kumar.
Good morning. We are really privileged to welcome the distinguished gathering for the inauguration of 3rd National Conference on Antimicrobial Stewardship Program on behalf of AIIMS. To start with the inauguration, I would like to invite our honorable dignitaries to kindly grace the dais. May the divine goddess bless us all. Now, light is a symbol of truth, knowledge, and understanding. It acts as a guide, keeping us from stumbling in dark. So, I would like to invite our respected dignitaries to light the lamp and guide us through this journey of knowledge. Respectfully invite Dr. Pratyusha Ma'am, Associate Professor, Department of Microbiology and Organizing Secretary ASPICON for the teacher, a motivator, always ready to guide us through new paths. She is a competent teacher and researcher projects in her name. Allow me to invite Dr. Pratyusha Ma'am.
Since we are running out of time, I'll keep my welcome speech short and sweet. A hearty good morning to one and all. Everything that I have to convey to you all is just in two sayings. As you sow, so shall you reap, and prevention is better than cure. Because years of antibiotic abuse and overuse has led us to a place where we are having very few weapons left in our armory to attack the pathogens, and instead of searching for a drug, a new therapy or drug over the horizon, it is much better that we learn to adopt preventive measures and other techniques to reduce the resistance that is there at present, for which we need antimicrobial stewardship practices. So we are all gathered here on this pleasant winter morning for this course, which is going to be aired by our ASPICON 2021. So on behalf of the organizing committee, I extend a heartfelt welcome to our director, Sir, Dr. P.K. Singh. Sir is often described as a visionary because he has truly led our institute to great heights and has always been an inspiring light for us. So welcome, sir. A hearty welcome also to our Dean, Sir, Dr. Umesh Badani. Sir is an enthusiastic academic and scholar with a very progressive view, and he is also an enthusiastic artist. He has actually painted a very lovely picture which depicts the race of mankind against pathogens. So a very warm welcome to Sir. I extend my heartfelt welcome to our medical superintendent, Dr. C.M. Singh, sir. So, sir is a very charismatic and efficient administrator who also happens to be the chairman of our HICC. And with a small smile on his face, he has always led us in the right direction. So, welcome, sir. We also have in our midst Dr. Nusrat Shafiq and Dr. Prasanna Kumar Panda, the President and Secretary of SASPI respectively. Now SASPI is the first organization of its kind in India to root for antimicrobial stewardship practices, and it is the encouragement and the guidance that we have received from them as well as from Dr. Sagar that has actually resulted in the conference where we are seated today. So a very warm welcome to Dr. Nusrat ma'am and to Dr. Prasanna sir. A warm welcome also to our ever motivated organizing committee which is seated. So we have our leader and champion, our HOD, Dr. Bhaskar. A warm welcome to sir. Our silent, strong and always scientifically correct Dr. Vinod Kumar Pati, who is also our co-organizing chairperson. The ever ready and master of all trades, that is Dr. Asim Sarfaraz, our co-organizing secretary. And yours truly, the organizing secretary. Right. And obviously we have prominent and well-renowned academicians from all over India and even across the globe who have got all their enthralling lectures for all the delegates. So a very, very hearty welcome from our side to all the guest speakers. And a very warm and hearty welcome to all the delegates, both offline and online, whose thirst for learning has resulted in a whooping number of registrations actually for our conference. So hearty welcome to all of them. And my words may inspire, but it is actions that actually take us to the next change or stage. So I cut short my welcome address and let us go ahead with the inaugural. Thank you so much.
Invite Dr. Prabhat Kumar Singh sir, Honorable Director sir, AIMS Patna for inaugural speech. He is a visionary, great leader who stood as a great pillar and led AIMS Patna to great level even during pandemic of COVID-19.
From SASPI, Dr. Nusrat Shafiq and Dr. P.K. Panda, welcome to AIMS Patna and welcome to this conference. Then personalities from the AIMS Patna, our Dean, Dr. Umesh Vadani, Dr. C.M. Singh, then the members of Department of Microbiology, the head of the department, Dr. Bhaskar, Dr. Vinod Pati, Dr. Asim Sarfaraz and Dr. Pratyusha, all the invited faculty members, guest speakers, faculty members of the institute, delegates, those who are present here and those who are connected online. So very warm welcome to AIMS Patna and to this inaugural ceremony of this SPCon conference 2021 on a very important theme, that's the Antimicrobial Stewardship program. This has been going on for quite some time, and because of the fact that we all are concerned about developing the antimicrobial resistance, and it is really a great concern which has been recognized by every one of us and by the WHO as well. As one of the important threats amongst the 10 important threats which has been identified by the WHO. So it is really a very serious issue, and we are all concerned about what is actually having seen in last so many years. We know there is issues as regard to the development of antimicrobial resistance, but it does not translate into our actions, and it has not yet translated to our action to the extent which is expected from all of us. Though there are a number of programs are going on, Stewardship program, and there is very active engagement of every clinicians and persons who are working in the laboratories, and a lot is being done, but the desired result is still not very close to us. And I'm sure through this conference, we will further increase or make our resolve stronger to fight against this menace, which is creating problem, and it appears that it will be much more in the future as well, until unless we take some very concrete decisions to fight the infection and the resistance which is developing against our antimicrobial agent. So I'm sure the discussions in this conference will be very fruitful, and you will enjoy all this. And I congratulate the department for organizing, having such a wonderful arrangement for academic feast and otherwise also. Thank you so much.
I'd like to request Dr. Bhaskar sir to present a memento to the director sir. Now, I would request Director Sir to inaugurate Society of Antimicrobial Stewardship Practices in India, that is SASPI website. Now, I would request Dr. Nusrat Safiq Ma'am, SASPI President, and Dr. Prasanna Kumar Panda Sir, SASPI Secretary, to come and present SASPI Charter to Director Sir. Thank you, sir and ma'am. Now I would request Dr. Nusrat Safiq ma'am to introduce us to SASPI.
Thank you, everyone, and a special thanks to the director for gracing this occasion and giving the occasion its due importance. With this, I would also like to, in the same breath, I would like to thank the organizing committee for providing an opportunity to the Society for Antimicrobial Stewardship Practices in India, this platform for inauguration. Thank you so much. Just a few words before I hand it over to our General Secretary, who's worked so hard for bringing the society to its current form, that is we are moving towards something like an organization, so which is a big step. We have been meeting over, say, last 3 years formally, and of course with the interruption that was brought in by the pandemic, but 3 consecutive sessions have taken place. And besides this, a lot of informal sessions have taken place. We were talking endlessly about antimicrobial stewardship, AMR. Some of these people visited PGI regularly for various workshops, and then we collected again at the behest of Dr. Sagar in AIMS Bhopal. So basically this was a work in progress which has now formally acquired some kind of shape, and we have jotted down our activities. We have laid out a plan for our future objectives. The basic agenda is that it doesn't have to become any one of those societies wherein we would just like to have some position there. It has to be a scientifically oriented society wherein we propose to carry out various activities, develop different guidance documents which can not only be used by the institutes who are involved currently, but could be of use to the whole country. So with these words, I would like to request Dr. Panda to come and deliberate upon briefly deliberate upon the objectives which all of us have laid down for the society. Thank you so much. Thank you.
Thank you, ma'am. And again, my love to all the audiences here, including my love to the dignitaries. And I will one disclosure ki more often I will more speak in Hindi because as a country demands this, and I hope you will not mind if you could not understand this part, but the real truth is actually we always understand in our basic language, that is Hindi as a Rajbhasha. ये सोसाइटी हम लोग एक्चुअली 2018 एक आस्पिकन किए थे जो 2018 ऋषिकेश में एम्स ऋषिकेश मैं वहाँ पे एक फैकल्टी हूँ डिपार्टमेंट ऑफ मेडिसिन कंसर्निंग द आईडी डिपार्टमेंट एंड वहीं से हम स्टार्ट किए थे जितने भी सेंट्रल इंस्टीट्यूट है स्पेशली ऑल एम्स ऑल पीजीआईज एंड अपार्ट फ्रॉम दीज ऑल्सो अदर इंस्टीट्यूशन एंड हमने फोकस किए थे कि जितने मेडिकल इंस्टीट्यूशन है स्पेशली दैट विल फोकस इन द स्टेप 1 लेटर ऑन दैट विल बी मोर ऑफ सेकेंडरी टू वेटरनरी और इवन एग्रीकल्चर सोसाइटी बिकॉज एंटीबायोटिक वहाँ पे भी यूज होता है, आप सभी को पता होगा। तो इसमें एक गेट टुगेदर और कोहेसिवनेस और इंक्लूसिवनेस सोच के हमने ये स्टार्ट किए जस्ट इज ए प्रीलिम स्टेज यू कैन टेल। हमने एक सोसाइटी वेबसाइट भी डेवलप किया है, आप सब टाइप करके जा सकते हो SASPI.in जस्ट SASPI SASPI.in सिंपल एंड SASPI नेम itself suggests its all objectives like Society of Anti-Microbial Stewardship Practices India। ऐसा नहीं है कि सिर्फ हम एक्चुअली ह्यूमन बींग का बात करते हैं, यहाँ पे एनिमल्स एंड प्लांट्स की यूटिलाइजेशन जो भी होता है उसके भी बात होगा, बट स्टेप वाइज हम लोग आगे जाते जाएंगे। और इसमें जो बहुत सारे ऑब्जेक्टिव्स है स्पेसिफिकली, तो मोर फोकस इज देयर कि हम लोग क्या करना चाहिए और क्या कर रहे हैं, उसके आगे हमारा फ्यूचर प्लान क्या है। तो उसी के टारगेट के हिसाब से हमने बनाया इंक्लूजन ऑफ 3 पार्ट्स। वन इज इन्फेक्शन प्रिवेंशन स्टीवर्डशिप जो हम लोग यूजुअली करते आ रहे हैं और उसको इतना अच्छा बना सकते हैं। सेकेंड इज डायग्नोस्टिक स्टीवर्डशिप जो हर क्लिनिशियन डायग्नोसिस बनाता है उसको अच्छा कितना कर सकता है। एंड लास्टली प्योर एंटीमाइक्रोबियल स्टीवर्डशिप जो यूटिलाइजेशन का जब बात आता है, तो देन वी हैव कंबाइंड दिस 3 स्टीवर्डशिप इनटू वन फॉर्म दैट इज इंटीग्रेटेड एंटीमाइक्रोबियल स्टीवर्डशिप दैट इज IAS। तो दैट IAS प्रैक्टिसेस टू बी कवर्ड इन दिस SASPI society and इसमें everything will be there, all the guidelines what are available till now and what will be available in the future that will help, and what publication and journals also it will contain, and what observation feedbacks that will be can be considered also it will be there. Ultimately who are the members, simple एक ही भाषा है कि everyone can be a member who are partly or completely involved in these IAS activities because integrated antimicrobial stewardship हम जब एक साथ लेंगे तभी जाके हम उसको antimicrobial prevention रेजिस्टेंस को प्रिवेंट कर सकते हैं और मोर इम्पोर्टेंटली वी हैव ए बेटर क्लिनिकल आउटकम। ये सभी को पता है कि आप एक पार्ट ले लो दूसरे पार्ट नहीं लो तो कोई क्लिनिकल आउटकम नहीं होगा। जब हम डायग्नोसिस नहीं सही किया कितने भी अच्छा एंटीबायोटिक देते रहो तो क्या फ़ायदा होगा। तो सो सिंपल कि हम सभी को एक साथ आगे जाना पड़ेगा। उसी एक साथ के साथ and this small initiative from all the central institution, now it is around 10th institution is there, but जैसे अभी आपको पता होगा बहुत सारे एम्स हमारा खुल चुका है and all एम्स will be come together actually in this, and next year you will see another एम्स will conduct this ASPICon and there you will see कि more advances तब तक हम कुछ आगे चले गए होंगे and I hope with this and you will get all the information in the website. And again thanks to AMS partner especially to inaugurate and to start, and I will again tell to beloved director sir PK Singh sir हमारी सोसाइटी सर एक रजिस्ट्रेशन एक्चुअली हो गया है, आज फाइनल एक्चुअली आ जाएगा. इट इज़ अंडर द उत्तराखंड गवर्नमेंट बिकॉज एम्स में इसका ऑफिस है. एंड जैसे फ्यूचर में इसका और सर पब्लिकेशन सब आते जाएंगे तो ऑल वेबसाइट में आते जाएंगे. एंड अगेन थैंक यू टू ऑल.
Forward to the presence of Dr. Umesh Badani sir, Dean, AIMS Patna, a motivator, approachable and friendly teacher and guide. He has authored many research articles and books and served as editorial member and reviewer for several international journals. Sir, kindly grace us with your words.
It is present online and offline here in this gathering. The whole organizing team needs a big round of applause for initiating after such a difficult time, and as we all know, this war which was being fought, I always tell that the First World War and Second World War we saw, but before the First World War even another World War was started, that was between microorganisms and macroorganisms. And human being is also one macroorganism. They want to, some of them, not all, there are friends also in microorganism, there are enemies in microorganism. They want to kill us, we want to make them away from our life. And this war is going on. We make antibiotics, they do mutations. Mutations is a normal process, we all know. Now we are, the new mutation gene, Omicron, is coming. So like that, this is how, and this team all over the world has to prepare this. So our society chooses our microbiologists to tell about those enemies who are not visible with the naked eye, but they make it visible through their knowledge and expertise to whole world. And not only the clinicians and others and planners are able to fight that, but without the microbiologists, it is almost impossible to go ahead. So with these small words, I must congratulate the whole Dr. Thakuria, Dr. Vinod Pati, and every evening he put a newsletter in our COVID for the, and there was a time when we used to see less positive cases, then lot of positive cases, then no positive cases, negative cases, this whole team of microbiology, and still we think that disease is decreased, but their work actually has increased in this time. With this, we must give them a congratulation as well as best wishes for the another 2 days conference here. Thank you very much for inviting me for this. Thank you.
Request Dr. Vinod Kumar Pati sir to present a memento to Dean sir. I am honored to request Dr. C.M. Singh sir, Medical Superintendent, AIMS Patna, for his kind words. He is a very versatile person, a passionate teacher, and determined to take our institution to next level. Sir, kindly grace us with 2 words.
Secretary SASPI, Dr. P.K. Panda, Head of Department of Microbiology, Dr. Bhaskar, Dr. Vinod, Dr. Asim, and other faculty members of different department of AIMS Patna, delegates both offline and online. Very hearty welcome to AIMS Patna and very good afternoon to all of you. As we know, the discovery of antibiotic was one of the biggest discovery of our saving the human mankind. But we know due to misuse or overuse or non-compliance of the patients, it's becoming resistance day by day. The problem due to antibiotic resistance, we all know, and basically all are expert over here, In case of tuberculosis, we are facing a significant problem, and tuberculosis again is leading for death to the many patients. Multi-drug resistant tuberculosis is a big challenge for this time, I think. The association like SASPI are very much needed to combat this situation. I think they have very big responsibility on their shoulder, and they have to see how they can overcome this problem. Department of Microbiology at Amsp is working very hard, not only in COVID time, what Sir has told, Professor Badani had told, and they are working very hard for infection control in the hospitals. And I know they are very, academically they are very sound, and they will be doing something to overcome the resistance in this hospital and in this country and this world. I congratulate the departments, head of departments, organizing secretary and other faculty for organizing this conference, and I am sure the deliberation of the conference will be beneficial for delegates, and after deliberation something will come out by which we will be able to reduce the antibiotic resistance. Thank you, thank you, thank you.
Thank you, sir. Next, I would like to invite Dr. Asim Sarfaraz sir, Assistant Professor, Department of Microbiology, Amsp, and Co-Organizing Secretary of ASPICON for a vote of thanks. Sir is one of the most polite, respected, admired, and dynamic teacher. He has plenty of publications to his credit. Sir, I request you to come and for the vote of thanks.
Sir, respected faculties, respected dignitaries, and all, it is an honor for me to propose the vote of thanks to this august gathering. It is a great privilege to acknowledge my heartfelt gratitude to our Director Sir for gracing the occasion in spite of his busy schedule and guiding us during the preparation of this conference. His active interest and valuable suggestions has been a constant source of encouragement for us. We thank you, sir. We are also grateful to our Dean Sir for his continuous encouragement, moral support, and words of advice during the conduction of this conference. Thank you, sir. It is with deep regards and warm feelings that we express our gratitude to our MS Sir for his valuable guidance and wise suggestions. Organizing a conference is an arduous task. I express my thanks to the organizing chairperson, co-organizing chairperson, secretary, treasurer, and the organizing team for their vision, meticulous planning, and commitment for organizing this event. We are really indebted to the President, General Secretary, and other office bearers of SASPI for helping us from the initial planning to final preparation of this conference. Please accept our regards. And I also extend my gratitude to the faculty members of Amsp for their valuable contribution, guidance, and support. I would like to extend my gratitude to all the eminent speakers who are champions in their respected field, and despite their busy schedule, they were very humbly able to accept our invitation and grace this dais for this conference. No conference is complete without the participation of the audience. I thank all the distinguished invitees for accepting our invitation and attending this conference and making our efforts look worthwhile. I find no words to express my appreciation to the residents and students of our institute for their hard work. They have worked day in and day out for organizing this event. I owe special gratitude to the staff members who have also worked hard for making this event a success. Lastly, I would express my thanks to our sponsors for their valuable contribution, and I hope that all of you have a great stay during this conference. Thank you.
Break. I would request the guests to assemble in hall after the break for scientific session after that. Thank you.